Um, I'm just checking if Rishikesh, Rishu, and Ravi can switch on their cameras, if that is okay. Um, and then we can go ahead with the introductions.
You start, Rasika.
Yeah. Also, just to note, Upul and Leah, we have these patient advocates from India, and they're more comfortable speaking in Hindi or Marathi, which is their local language. So when I ask a question to them, I'll translate the question and ask, and they will be answering in their language, but I'll make sure that I summarize what they've said. But I hope you are okay with that because we we are now an international panel, so yeah. And I don't know how AI works. We were expecting that it will do the live transcription, but I don't know if that's going to work. I never trust the technology, so I'll do that myself. But yeah, just wanted to give a heads up. Um, Welcome, Rishikesh, Ravi, and Rishu. Uh, I'll just start with the introductions. Ravi Kumar, as you can see, is a patient advocate who is 24 years old and was recently diagnosed with lung cancer and has since then joined Lung Connect and has been advocating for lung cancer patients. Rushikesh is again a patient advocate who was diagnosed at 23 years of age and since then has also been advocating for patients and for rights of lung cancer patients. Rishu Kumari is also a patient advocate. She is a caregiver to her brother who is 26 years old and was diagnosed with lung cancer. I can see that Dr. Rishabh Kothari has joined us. Um, are you there with us, Dr. Rishabh? So Dr. Rishabh is a senior consultant at Oncomen Cancer Center, Ahmedabad. Then we have Leah, who is also a patient advocate and a co-founder of Young Lung Cancer Initiative from USA. And we have Dr. Upal, which all of us have met a lot of times, who is executive director of Research Longevity Foundation. We're expecting Dr. Ulas Batra and Dr. Kumar Prabhas to join, who both are oncologists from India. And when they join, I'll make sure to introduce them. And as of myself, I'm also a patient advocate and a public health researcher, and I was also diagnosed with lung cancer when I was 26 years old. Um, so I'm just super excited about today's webinar because we have everyone who have been touched with lung cancer directly in some or the other way on this forum, and I'm sure we'll have a great conversation today. So just starting with the topic and what we are going to talk today. So our objective for today is to shine light on lung cancer in younger adults who have never smoked, a group that historically was under-recognized, and to explore how we can improve awareness, diagnosis, care, and support for these people. Um, so, from the limited research that I have done, I've come across some numbers which show that about 75% of lung cancer patients are under 40 years of age and were non-smokers, uh, versus only about 40% of those over 60. So, the numbers itself tell a lot of the story. Um, and I can see that Dr. Kumar Prabhas has joined. Welcome, Dr. Kumar. Just
Thank
a
you.
quick
Thank you.
introduction
Good evening,
about.
everyone. I'm Kumar Prabhash. I'm medical oncologist and I work at Tata Memorial Hospital. Thank you.
Thank you, Dr. Kumar. Um, And we just wanted to start this webinar by understanding the changing demographics of lung cancer, especially in young adults and those who've never smoked. So, Dr. Kumar, I wanted to ask this question to you uh, first. And I think this is the question that comes to every patient's mind: that why are young non-smokers getting lung cancer, and what should patients and caregivers know about early symptoms, and why are they often being missed?
So, in Indian context, we do have a fairly good number of patients who is, young. In fact, if we take less than 50 years of age, almost 40% of our non-small cell lung cancer, they are, less than 50 years of age. Which is a bit different from Western world, which is there. And second, we don't have a lot of prevalence of smoking in our country. So tobacco chewing is very high. Almost 40 to 50% of our population, they chew tobacco. But if you take smoking, that is not so common. That is around 12 to 15%. That's the average smoking rate in Indian context. And that may partly explain why that we have a good number of patients who are non-smoker. uh, Now there is an issue regarding that. If they are non-smoker, then why do we have those lung cancer patients? And at this moment we don't understand it completely. There are some anecdotes which explains this, and one of them being secondhand smoking, then pollution being one of the factor which is has been under investigated. Lung injury has been very well documented, but does they lead to lung cancer? In Indian context, it is under documented, but there is a good data from China, especially for indoor pollution, which is a similar situation in India, because now also good number of our women in village, they end up having cooking at home with woods, and using things which leads to a lot of smoke inside. And apart from that, external pollution, which is well known. There is also a recent data regarding that you do have almost 10 to 15% of the patient where you can have a germline mutation in lung cancer, which we have not thought earlier. Now, they do lead to hereditary lung cancer or not, that is again at this moment not as well documented as what we know for breast cancer. So we do have various reasons for having younger population and non-smoker having lung cancer in our country. Many of them needs investigation, and also there is a pattern to it that where they happen. So if you take Northeast, we have a good number of patients having lung cancer as compared to, and almost the rate of lung cancer is similar to what we have in Western world. But if you leave aside Northeast, the lung cancer rate in Indian population is almost one third of the what we know in the Western world. So we do have some of the unique property, and which many of them we don't have answer at present.
Thank you, Dr. Kumar. And thank you for explaining and giving us this wider picture of what all uh, could happen and what all is happening out there. And I think when we go ahead in the webinar, I'm sure Dr. Upul will also shed some light on the research from an international perspective. So just going ahead, I want to uh, ask Ravi, who's a patient advocate, and just hear about his story and how he was diagnosed, um, and try to relate to this picture that Dr. Kumar has told us about. So, रवि जी, क्या आप बता सकते हैं कि आपका डायग्नोसिस कैसे हुआ था, और आपने क्या सिम्टम्स एक्सपीरियंस किए थे, और अब आपको क्या लगता है कि तब आपको मदद मिलती या कुछ बेहतर होता तो आपकी जर्नी थोड़ी आसान होती?
अ, मैम, शुरू में मुझे एक नॉर्मल खांसी हुआ था। तब मैं दिल्ली में बिहार लोक सेवा आयोग की पढ़ाई कर रहा था। तो मुझे लगा कि हो सकता है पॉल्यूशन की वजह से मुझे खांसी आ रहा है। तो कुछ महीनों बाद धीरे धीरे क्या हुआ कि बहुत सारे समस्याएं आने शुरू हो गई। तो मैं वहां से फिर तुरंत घर लौट आया। तो मुझे लगा कि मैं गया और एक्सरे करा के डॉक्टर से मिला। तो मिलने के बाद डॉक्टर ने बोला कि आपको टीबी है। तो हम यहाँ से फिर उन्होंने बोला कि आप एक जगह चले जाओ, वहां से आप अपना इलाज लो। तो ऐसे करके मैं 1 महीने जो था कि दवा लिया, ट्रीटमेंट लिया वहां से। फिर कोई इम्प्रूवमेंट नहीं दिखा तो फिर हम दूसरे डॉक्टर के पास गए। तो वहां से क्या हुआ कि उन्होंने बोला कि आपको सार्कोइडोसिस लग रहा है, कि सार्कोइडोसिस की संभावना है। तो उन्होंने 1 महीने का वहां पे मतलब सार्कोइडोसिस के आधार पे मैंने भी 1 महीना दवा खाया। बट बहुत ज्यादा साइड इफेक्ट होने की वजह से मैंने दवा बीच में छोड़ दी। फिर क्या हुआ कि मैं एक लोकल डॉक्टर से मिला तो वो बोले कि आप बनारस चले जाओ और वहाँ पे इस अस्पताल में अपना ट्रीटमेंट कराओ। जब मैं वहाँ गया तो मेरे सारे टेस्ट हुए। तो फिर उसके बाद उन्होंने बोला कि एक ब्रोंकोस्कोपी करके देखते हैं। तो उसमें क्या था कि मिलिग्नेंसी डिटेक्ट नहीं होता उस समय। तो फिर उसके बाद उन्होंने कहा कि एज पर जीलियस करके हम एक मिनी करके टेस्ट करते हैं आपका। तो उसमें डिटेक्ट हुआ था कि मेरे लंग्स में फंगल इन्फेक्शन है। तो फिर उसका भी मैंने 1 महीने दवा खाया। तो उसके बाद मेरा जब ऑक्सीजन लेवल एकदम 46 पे आया तो फिर हम तुरंत भर्ती हुए वहां पे। उसके बाद 13 जनवरी 2025 को रिपोर्ट आया मेरा, तो मुझे मेटास्टेटिक एडेनोकार्सिनोमा फेफड़े का कैंसर है, लंग कैंसर है। तो मैम वही था कि बहुत खराब लग रहा था, बुरा लग रहा था कि 24 साल की एज में कैंसर डायग्नोस हो रहा है। और मैंने कभी स्मोकिंग भी नहीं किया था, ना ही कभी शराब पिया था। तो ऐसा करके फिर मैम लक्षण वगैरह
जी।
मेरे लक्षण थे वो सांस फूल रहा था मेरा, सीढ़ी नहीं चढ़ पा रहा था, लगातार खांसी आ रहा था, और थकान, कमजोरी, और एक लंग्स में घरघराहट जैसी आवाज आ रही थी उस समय। 1 महीने में मेरा वजन जो था 5 से 6 किलो कम हो गया था। फिर मैं जब भी डॉक्टर से मिला, वहां पे जितने भी डॉक्टर से मिला, तो उन्होंने हमेशा मुझसे पूछा कि क्या आप स्मोकिंग करते थे। तो जब मैं उनसे मैंने तो कभी स्मोकिंग किया नहीं था, बट उन्होंने कभी इस संदेह की नजर से नहीं देखा कि मुझे कैंसर भी हो सकता है। तो ये चीजें हैं। और वो बाकी उसके बाद फिर मैं जब गया तो ट्रीटमेंट होना स्टार्ट हुआ, तो ठीक है अब फिर।
जी रवि जी, थैंक यू सो मच शेयर करने के लिए। Just for context, Leah and Upul, and for all of our international audience, what Ravi shared is that when he presented to the doctors with his initial symptoms, he uh, was suggested to have tuberculosis, which is a far more common diagnosis in India, and then was also started on medications for it. Then he was suspected to have sarcoidosis, if that's if that is what I got from his story, and again was suggested medicine for that, and then some lung infection, but no one thought that it could be lung cancer. And of course, as a patient, why would Ravi think that it would be cancer? So this just suggests that even the medical system were probing Ravi for other diagnoses. And the first question that was asked to him was whether he smoked. And because the answer was a clear no, all the other diagnoses were first given more importance and was even started on medications for them. So after hearing this, Leah, I would really want to hear from you about uh, what is the scenario internationally, and if you could also share with us what you see as the top three challenges faced by lung cancer patients internationally, and what are the coping strategies that are emerged effective?
Yes, so my story is very similar as well as many patients that I talk to on a regular basis. The delayed diagnosis, or, going to the doctor but not meeting the stereotypical requirements or what people think is a requirement for lung cancer, saying that being asked right away if you've ever smoked and that answer being no, they kind of don't even explore that route. So lots of delayed diagnoses as well in the United States, especially in people under 50 who've not smoked. I think that is probably the biggest barrier right now is getting a diagnosis early, and where because many of us start experiencing symptoms much earlier than when we were diagnosed, anywhere from a year, 6 months, 3 months. We've heard all the different timelines, and what happens in that time could really change the stage of your lung cancer. I think that's probably first and foremost in the United States right off the bat. And then secondly would be biomarker testing. Having the option presented to you for biomarker testing and the explanation as to why the biomarker testing is fun or is important, or the next generation sequencing. And then in some states, getting your health insurance to pay for that testing is another big issue that we hear in the United States. When I think globally, when I talk to patients that live over, let's say in Europe, it's a lot of the same thing. It has to do with delayed diagnosis as well as insurance. Who's going to cover it? Is it warranted? And then really a lack of education just in the population of citizens to even think that they could possibly get lung cancer if they didn't smoke. In the United States, we do have a higher prevalence of smoking. And that's why I think it gets really jaded when it comes to diagnoses in the United States. I hope I answered all your questions. Did I miss something?
No, this was perfectly, yeah. And
Thank you.
it is interesting to know that although we have such different demographics between US and India, but the core problem remains the same. So it is actually interesting to hear about that. And yeah, thank you so much. You covered everything that we expected. Um, uh, I would now want to ask Rishu Kumari, who's a caregiver to her brother, about her story. रिशु, तो क्या आप बता सकते हैं कि एज अ केयर गिवर आप भी काफी यंग है और आपका भाई भी जो 26 साल के ही है, उनको लंग कैंसर डायग्नोस हुआ है, तो आपको क्या चैलेंजेस फेस हुए एज अ केयर गिवर टू अ यंगर
Yes, ma'am.
पेशेंट?
Good evening, everyone. My name is Rishu Kumari. I'm from Gaya, Bihar. मेरे भैया का नाम अभिषेक कुमार है। उनकी उम्र 26 वर्ष है। मार्च 2024 में सिर्फ उनको पेट में दर्द हुआ था और वोमिटिंग जैसा हुआ था, मतलब खाना पच नहीं रहा था। तो हम लोग डॉक्टर के पास गए, तो वहां पे उन्होंने कुछ टेस्ट वगैरह किया। उसके बाद उन्होंने बोला कि घर जाइए। फिर घर आए तो नेक्स्ट डे सांस लेने में पूरा दिक्कत होने लगा, पैर में पूरा दर्द होने लगा, खड़ा नहीं होने पा रहे थे, एकदम बहुत ज्यादा सीरियस हो गए थे। ऑक्सीजन लेवल पूरा डाउन होते जा रहा था। तो फिर हम लोग पटना में रूबन हॉस्पिटल में ले गए, तो वहां पे टेस्ट हुआ तो पता चला कि हार्ट में पानी भर गया है। तो फिर पानी निकाला गया और फिर वो टेस्ट के लिए भेजा गया। तो टेस्ट हुआ तो वहां पे टीबी का टेस्ट हुआ, तो टीबी कभी भी पॉजिटिव नहीं आई, लेकिन फिर भी टीबी का दवाई चला। और डॉक्टर ने बोला कि पॉजिटिव 90% में नहीं आता है, फिर भी टीबी का दवाई चलता है। तो टीबी का दवाई स्टार्ट हो गया। फिर उसके बाद 1 महीना के बाद फिर हार्ट में पानी भर गया। तो फिर हम लोगों ने पूछा कि जब ट्रीटमेंट स्टार्ट हो गया तो फिर क्यों पानी भर गया? तो डॉक्टर ने बोला ऐसा होता है, पानी भर जाता है, पेशेंट आते हैं निकल। उन्होंने मेन रीजन नहीं बता रहा था कि और भी टेस्ट होते हैं, ऐसा कुछ बताया ही नहीं। तो फिर हम लोग बैंगलोर गए, वहां पे भी इन्फेक्शन डिपार्टमेंट में भेजा गया। वहां पे भी उन्होंने इन्फेक्शन डिपार्टमेंट में इन्फेक्शन का दवाई चलाई और टीबी का टेस्ट वहां भी हुआ, बट टीबी पॉजिटिव नहीं आया। फिर भी टीबी का दवाई चलाए और 6 मंथ तक टीबी का दवाई चलते रहा। वहां पे भी कोई कैंसर का टेस्ट वगैरह या बायोप्सी वगैरह या कुछ भी ऐसा हम लोग को नहीं बताया कि ऐसा भी होता है। और 6 मंथ दवाई खाए तो उसके बाद वो बॉडी में और रिएक्शन कर गया। तो मतलब कि और वो यंग शरीर कितना झेलेगा, वो और बढ़ गया, बॉडी में बढ़ गया। उसके बाद जब हम लोग को पता चला कि बहुत ज्यादा सीरियस हो गया, फिर लंग्स में भी पानी भरने लगा, हार्ट से लंग्स में चला गया। फिर हम लोग ये टीएमसी वाराणसी हम लोगों को भेजा गया। वहां पे गए तो पता चला कि लंग कैंसर है, वो भी मेटास्टैटिक में जा चुका है। तो हम लोग ऐसा नहीं कि डॉक्टर के पास नहीं गए, डॉक्टर के पास जाते रहे, ट्रीटमेंट होते रहा, फिर भी हम लोग को बहुत लेट डायग्नोसिस पता चला। तो ये बहुत बड़ी हम लोग के लिए एक माइनस पॉइंट है जिसको बोल सकते। पता चला तो फिर इसका ट्रीटमेंट इतना महंगा है कि मतलब मिडिल क्लास फैमिली अफोर्ड ही नहीं कर पाता है। इतना महंगा दवाई, और फिर हर एक मंथली हमको चाहिए, तो नहीं हो पाता। और प्लस में जब फैमिली को पता चलता है कि ऐसा है, तो फैमिली भी बहुत ज्यादा परेशान होते हैं। और हर एक 20 दिन पे कीमो लेने के लिए जाओ। तो मेरे फैमिली में मेरे एक ही भैया है जिनको ये डायग्नोसिस हुआ। पापा है तो वो मतलब कि काम वगैरह करते हैं जिससे इनकम आए, तो हर 20 दिन पे मुझे ही जाना पड़ता है, मतलब कि हॉस्पिटल कीमो के लिए वहां पर लेकर जाओ। फिर और तो इससे मतलब कि मेरे लाइफ में भी बहुत मतलब इफेक्ट पड़ा है। इतना कम उम्र में इतना कुछ झेलना पड़ रहा है, स्टडी के साथ साथ इतना मतलब करो, और हर एक टाइम टाइम पे खाना देना, उनको क्या दवाई मिला नहीं मिला, क्योंकि वो मेंटली मतलब भी प्रिपेयर नहीं होते, बहुत कुछ नहीं बता पाते हैं कि बहन को बुरा लगेगा या ये क्या समझेगी। वो हमसे हेल्प भी नहीं लेना चाहते, बहुत कम हेल्प लेते हैं। लेकिन हम लोग को लगता है कि क्या करें कि उनको अच्छा लगे, वो हेल्प लेना ही नहीं चाहते। उनको लगता है कि मैं खुद कर सकता हूँ, लेकिन हम लोग को लगता है कि इतना बड़ा मतलब मुश्किल आ गया तो थोड़ा हेल्प दे। तो इससे मेंटली सबसे ज्यादा डिस्टर्ब हुए पूरा फैमिली। मैं भी बहुत ज्यादा डिस्टर्ब हुई हूँ। हर एक 20 दिन पे ठंडा हो, गर्मी हो, बरसात हो, एक तो बिहार से यूपी जाना, रात भर ट्रेन से सफर करना, फिर सुबह पहुंचना, नंबर में लगना, तो बहुत कुछ झेलना पड़ रहा है। लेकिन ये है कि अब थोड़ा थोड़ा सुधार हो रहा है, तो बहुत हेल्प हो रहा है। और गवर्नमेंट से भी कुछ कुछ मतलब हेल्प मिला तो फिर दवाई लेने में आसानी रहती है। लेकिन ट्रीटमेंट बहुत ही महंगा है। पेशेंट को लगता है कि ट्रीटमेंट अवेलेबल होने के बाद भी मेरे पे नहीं पहुंच रही है, तो एक
जी
पैसा भी बहुत बड़ा रुकावट बन रही है। ये मैं बोलना चाहूंगी।
जी रिशु, बहुत बहुत शुक्रिया आपकी स्टोरी शेयर करने
थैंक
के
यू।
लिए। So what I'm hearing from Rishu's story is three key points here. One, again, delayed diagnosis. Her brother was treated for tuberculosis, whereas he actually had lung cancer, for which he was never tested. Second, as a caregiver to a younger patient, she is expressing her concerns that her brother never tells or asks for help because he himself is in this emotional burden that being a young supposedly provider of the family is now asking for help, and he deals with that emotional burden. And third, again, this financial burden that I guess we all uh, can understand that every patient goes through. Uh, and again, it is interesting to hear that internationally and even in India, we are having these similarities between these three key points. And I can see that Dr. Ullas Batra has joined us. Thank you for joining, Dr. Ullas. Just a quick introduction. Dr. Ullas is a co-director, Department of Medical Oncology in Rajiv Gandhi Cancer Institute in Delhi. Welcome, Dr. Ullas. And after
Before you say
listening to
something, can just utter in Rasika?
yeah, sure.
First of all, I just logged in when she was sharing her story, and um, it actually jolted me. Something which is something, you just try to put yourself in her shoes, and just imagine you doing this for your brother, your relative, your mother. I was once a cancer caregiver for my mother-in-law, and it's difficult. I mean, those 4 months that we described, used to live in the hospital. It was my hospital in which we took treatment. But being a caregiver, sometimes I tell my patients, being a caregiver probably is more difficult than being a patient itself. The kind of stresses that we have to deal with, the financial, the everything, it's hats off to these people, and heart goes out to them. And second point is, thanks for making me a part of this. This is probably going to be more rewarding and satisfying than treating patients at 9 to 5. So thank you for getting me a part of it. Thank you.
Thank you. Thank you so much for joining us, Dr. Ullas. And I do have a question for you now,
Sure.
because Leah, who is also an international patient advocate who joined with us, also shared similar story of delayed diagnosis and financial difficulties, even in US. And after hearing Rishu's story and Ravi's story, these were the same concerns raised. So my question to you is, in India, literally every single patient, every single young non-smoker patient will tell you that they were first treated for tuberculosis, and then when it didn't work or exaggerated the situation, were then tested for lung cancer. So from a clinical standpoint, what are your thoughts on this?
Absolutely agree with that. I think it stems from a two-way problem. First of all, the clinicians don't want to believe, they don't believe that any young person can get cancer. The lack of education, lack of awareness amongst clinicians also is there, which believe that, it cannot happen to a young individual. It is lung cancer is a disease of smokers, elderly, males. So the first diagnosis is never towards that. The second is patients don't want to believe. If I ever do ask them for a pleural tapping or an FNAC or a biopsy, at least in the private sector, they'll go to someone else. So you don't really want to say that. Third is empirical ATT. Since empirical ATT is very easily available in our country, it doesn't harm to give, from a clinician's point of view, a trial of ATT and then see how the patient responds. But that 6 weeks is something which is, first you have 6 weeks, then the patient comes later, the follow-up is not there, and that leads to a lot of issues. So I think educative sessions like this, maybe when we reach out to a normal oncologist physician gathering, making people believe that cancer is not only a disease of adult, and numerically there are more people, there are more and more people in the 20 to 40 age group also that can get cancer, is also very, very important. Even at cancer center, I have seen sometimes, when they do a biopsy, they don't test for tuberculosis. They don't set a gene expert or something which can go over there. So educating the patients, educating the clinicians, and educating the oncologists, and awareness amongst all three is very, very important. And say no to empirical ATT. I mean, that is something which I'll say. Say no to empirical ATT. I mean, no diagnosis of tuberculosis. Nobody should get an empirical ATT. Nobody should get ATT without some kind of proof of that. That is what I would probably suggest.
Thank you so much, Dr. Ullas. And your words are really big and really mean a lot, because you said that all the three people involved, the patient, the clinician, the oncologist, all of them need to get more educated, and we need to raise awareness, because we often hear that the burden is always put on the patient's shoulder. But it's really nice to hear from a clinician that even clinicians bear that burden.
So can I also
And
come in and probably suggest, Kumar, probably we can do a young cancer. I know Prabhat is doing research on that, but probably put in all our patients, get our paper of young lung cancers, and put it across, and spread the awareness with that. Because see, the point is, if I say it will have this much impact, if Kumar says it will have this much impact, but if both of us say and we have a paper, it will have this much impact. So if we can, I mean, the data, scientific data also needs to come over here. Let's collate our patients. Let's actually see how much is the burden of cancer in the young. And once it goes over to the scientific journal, I'm sure, see, how I got into this is because of Kumar. Kumar Prabhash is one responsible for this. He told me, jitna bhi hai data public domain mein dalo. So I think if 3-4 centers come over there together, collate their data, put into scientific domain, people will start leading, people will start learning. We will have more evidence to show to a normal clinician also. Kumar.
Always happy to work with you, Dr. Ullas. We will collate it together. I assure you that we will.
And we should also encourage and tell people, that there is lung cancer is not only a disease of non-smokers, this, that, and the things. I mean, you need to publicize it more important.
I agree with you. I agree with you, Ullas. Sure.
Absolutely, Dr. Ullas. And yeah, I think this webinar, if this acts as a starting point for such a great initiative, that would be really amazing. And I would also want to rope in Dr. Upal here, who is the research mind for a lot of people, and Lung Connect has always seeked help from him for all of our research initiatives. So Dr. Upal, I would like to know your thoughts now on, now you've heard all these stories about delayed diagnosis and tuberculosis being the main diagnosis. So what are your thoughts about what research direction could help improve outcomes and enable earlier detection, both internationally, or if you have something specific to share regarding India, that would be really helpful.
Thank you, Rasika, for inviting me for this webinar, and it's an absolute honor to share space with this amazing group of individuals. I wanted to pick up on Dr. Prabhash's point earlier on, where he said that the biology of young lung cancer is very unique. And I'm going to sort of attach that to Dr. Batra's point on putting data out in the public domain. So in terms of research projects, I think the first project that comes to my mind, and I think that's true for India and for from a global perspective, is the more sequencing we can do, the more information we can gather from tumors from young patients. I think the more information we'll have. And we already know that the chances of finding a targetable mutation that has a treatment associated with it, the chances of finding such targetable mutations in tumors from lung patients is much higher. But I think if we do more and more sequencing, I think we'll have a better idea of other genetic risk factors that could be associated with the development of young lung cancer. The other piece, which is sort of associated with these risk-based analysis, is the fact that, when we think of lung cancer, we think of tobacco. But the reality is that everyone who has tobacco exposure, everyone does not get lung cancer. So it's not 100% causation, right? So that obviously tells us that even with tobacco, there are other factors that lead to the development of lung cancer. And we have some idea of this right now, pollution being one, radon being another, and there's, of course, genetics and occupational exposure. But the more we sequence and the more we associate that with a person's history, I think we'll have a better idea of what are some of those risk factors that can then be used to define screening criteria for high-risk individuals. And that is because of the fact that right now, most people who are diagnosed with young lung cancer, they do not qualify for lung cancer screening. And I think we need to keep that in mind. And I think we need to re-envision, rethink, how can we use biology? How can we use epidemiology to develop screening criteria for high-risk individuals? And this is true across the globe. Now, in terms of a research project that just came to mind from an India perspective, and I was honestly shocked to hear Raviji's story that he had to go through tuberculosis treatment, then sarcoidosis, and then aspergillosis, and Rishuji's brother's story that the doctor said that even if in 90% of cases the TB test is negative, you will still start ATT. And I'm going to pick up on Dr. Batra's point, right? He said that unless there's a confirmatory test that's clearly showing that a person is positive for TB, then ATT should not be started. And I would say that in this situation, especially in a country like India, where chest X-ray is often done, how about using chest X-rays that are being done for tuberculosis detection and using maybe AI or some other technology to mine these chest X-ray data to identify if people who are symptomatic could potentially also have lung cancer. That's sort of the second project in my mind that I feel could be very important from an Indian perspective. And the third project, which I think again is global, is I think doing more of patient experience work, but focusing on the younger population, because as Leah, as Rishuji, as Raviji pointed out, these are all young people and they are in the prime of the economic productivity life. And they're also, in my mind, navigating being parents, being caregivers to their own parents. So it's a very unique population. This is not on the, this is not, their needs are very unique and very different. And I don't think we have a good understanding of the needs of the young lung community. So the more patient experience, the more needs studies we do, I think we as a community will be better equipped to not just treat young lung cancer, but also support their other needs.
Thank you so much, Upul. And yeah, thank you so much for giving so many research ideas. I just want to quickly check with Dr. Ullas and Dr. Kumar if they have something to add on to whatever Upul has said. And if possibly there is some way that we can also rope in Upul in the previous research idea that we were discussing.
Dr. Kumar first.
So I agree with all the suggestions. In fact, they are very useful ones. And sequencing, we have done some reasonable number of sequencing. I do agree we haven't done more comprehensive ones. The limited sequencing, we have done reasonable number, and totally agree with you. Almost young non-smoker adenocarcinoma, almost 2/3 of the patient has a driver mutation. So absolutely right that this is true. And we did publish almost 5,000 patients data, and another one is 1,200 patients data, and that suggests similar finding. And I totally agree that we require more. In fact, we have done some germline sequencing. Hopefully, we will have some data regarding that in recent future. That is some 700 plus patient where we have done germline sequencing for lung cancer patient, and let's try to see that we get something meaningful out of it. And also the suggestion, the patient unmet need, that is very important. And I agree, many times we presume that what we talk to the patient in the OPD, and that is all they require. A systematic way of learning will be important, and I think so that is something is important, and it is lacking. And also different people from different areas, they have a different need, and we heard here also from patient and the caregivers, there were different issues at different places, what they were going through. And that we have from city where you have hospital, from villages, from middle city. There are different requirements for those where you have Ayushman card available or not, government helping or not, place for stay or not. In my OPD, when we end up evaluating patient, do they have money or not? Do they have place to stay or not? Do they have test available or not? And different group of people have different requirement. That is something we need to work harder on, which we have put a bit of effort. But I agree, maybe I think so. That is something we can do comprehensively. And now we know that Lung Connect having multiple people involved, or maybe in one of the forum we can have 8-10 people from different part of the country, not representing only one aspect, not only Delhi people. So Delhi people have only one part, one type of problem. If we are from 10 part of the country, then we will learn a lot. How different group of people have different issues. And Ullas knows at this moment I'm working at a place called Muzaffarpur, and this is one of the poorest district in the country. And trust me, it opened my eyes that how the needs for patients are different from, because I work in Mumbai and here both. Mumbai patients have different issues. They have a lot of issues, but Muzaffarpur people have different issues. So yes, there is a requirement to. In fact, we can take. I know that Dr. Upal works in this area. Dr. Upal, this will be useful if we can have framing of question and your help, so that we will be happy to implement that part.
Kumar, can I interject over here? And before before Upal interjects, so I think, you know, a lot of scientific work, research work has been done by Tata on a large scale, AIMS, and we are also doing some work. I think where we are lacking is what you just now said about the patients and the caregivers' perspective prerogative. We take decisions for them. Today, FLAURA2 data has come. I will presume that because 1 year survival is there, I will counsel the patient in such a way that, you know, this is better. If lorlatinib is not, I will tell them in that way. I think in India, we don't have that, you know, HRQOL from the patient's perspective. In the clinical trial also, you know, you have those things. I mean, come on. I mean, Indian guy has absolutely no issues about, I mean, you know, how frequently do you go and walk your dog, and how frequently do you go and meet your mother-in-law? Your mother-in-law stays with you, your dog doesn't even exist over there. So I think we need to have Indian specific questionnaire for the patients and the caregivers. But that, I think that is where we should take Upal's expertise and Lung Connect's practical, last level connectivity so that we can get the thing. But I wanted to understand from you, Dr. Kumar, after that, what? So today you have understood. Let's, you know, I mean, for me, everything is practical. So let's say I understood in Rajiv Gandhi, my people's problem is not residents, you know, something. So once I have collected that data, what people want, then what? After that, what happens? We get a publication, Upal gets some work to do. Then what happens?
So I'll tell you some, you know, and I have not done systematic, way of having unmet need, but Mrs. Vandana, she has worked with me, and I'll give you some examples how I learned, and then you realize that how it works. So one of the things I learned, and I work in, and for people who don't know me, I work in Tata Hospital. It is a public sector hospital, very busy one. So we realized that our patient unmet need was very small one. They didn't know where the rooms are. It used to take them whole day to go to one room to find out where the room number 43 is, where the room number 110 is. And that led us to partner with our NGOs to have the new patients, showing them where the rooms are. And now if you come to my OPD, I have one social worker only for this. I say, hey, please, you need to show them the rooms. And initially I didn't realize, okay, this can be such a big problem. Next, one issue was, as someone was telling, you heard that going and staying, this was a problem. Then again, with the help, Sanjeev is here. Sanjeev is here as a part of Lung Connect. So I took help of Sanjeev and his group, and we got one donor to make a place where they can stay. So there's a place called Navi Mumbai. They made 14-bedded area where those patients of lung cancer can come and stay.
Okay.
Another one was NGS testing, and NGS testing was always on my head, that how do we get it done? So then, Ullas is part of it. We made something called Lung Alliance, and we got as many donors as possible. That is not enough. And this year we have done 3,200, 300 odd patients till now, totally free of cost NGS testing in the country, where you have to go to the website, which is absolutely free of cost. Anyone can, click the button and get it done. There is no filter to it. The problem, then we realized that it has become so popular now that we are looking for more fund now. So we are struggling with that. And this came from, because in the OPD, and again, that doesn't mean I'm anyway discounting systematic way of knowing patient unmet need. But these were anecdotes which we could see in the OPD, and then go back and partner with Ullas, partner with Sanjeev, partner with Vandana. And Vandana was there. It is such a big loss for Mumbai. She's gone to Delhi. So I used to get very tough patient went for palliative care, and so many times I was not able to convince my patient, and I used to see there was a barrier. She was such a good at having counseling, that I used to take her help every now and then, and now also on telephonically I take her help. Again, Vandana is a part of, you can see her there. So it is, yes, we can provide some solution. And I agree, Ullas, that we have worked very well on treatment part, which we do. but this part we have done in bits and parts. I think so. That is where, if we work harder and try to get detailed, then if we solve out of 10 problems, 2 also, it will be useful. That's where I'm coming from. My apology for a lengthy,
I saw that, So I will ask everyone, when I and Kumar start talking, no, it's a Jugalbandi. We will not stop. We will chew each other's brains. So please, Rasika, ask both of us to shut up. At least you can ask Kumar and me, we are good. We will tell each other to shut up. And now taking a clue out of Upal, can you please ask Leah to come and,
So I saw the question in the chat about how is this in the United States in terms of patient voice being taken into account. And, I think my personal experience was it took several different oncologists at different hospitals to find one that would be open to letting my husband and I, my caregiver and I, have a say in how my care went. I also think it was a learning curve because in the United States, as women, we're told to respect men, and especially men that are, educated and they may be older than you. And sometimes it's intimidating to stand up for yourself and say, but this is not working for me. So that takes a little of coaching actually from other patients is very nice on how to bring this type thing up with your physician. But it is a big issue with a lot of times doctors just walk in and they have 15 or 20 minutes to see you and they say, this is, you have EGFR exon 19, you're taking Tagrisso and that's it, that's it. Where I think patients in the United States have a better kind of part in the whole plan if they're meeting with either a social worker or a nurse navigator, a nurse practitioner, a palliative care doctor. And not all hospitals and oncology centers have those at their disposal. The first place I was at did not have any of those things. And it was really me just getting online and going to EGFR resistors and longevity and GoTo and finding the questions I should be asking. But I think all patients want a say in their treatment, especially the younger population that has education at their fingertips. My parents are different. They look at the doctor to say, this is what you do, and they go do it. Whereas if a doctor tells me to do something, I can go home and get on the internet and find out 15 other options or what other people are saying about it. So I think a lot of times it is nice to include the younger population, and sometimes they don't want to. And that's just a simple question. Would you like to tell us how you would feel about treatment or what type of treatment you prefer, or how are you doing? And in the United States, a lot of times when patients are asked these questions about like, how is your treatment going? Even if patients are having terrible side effects, they don't want to say that they're having terrible side effects because they're afraid the doctor will take them off their treatment. And we all know what that means. So it's creating that environment with your patients that is welcoming and allows them to express their feelings, the side effects. And if they don't feel comfortable with the physicians leaning on their team of nurses or social workers or whoever they have around. But I think globally, this is an issue. We all talk about a lot of the oncologists are used to dealing in lung cancer world with older patients in the United States, especially. And the older patients are just willing to say, tell me what to do and I'll do it, where this is a new kind of group of patients, a new demographic, really.
Yes, thank you so much for sharing that, Leah. We haven't heard from Dr. Rishabh and Rishikesh yet, so I'll just have them talk a little bit now. Dr. Rishabh, if you're there with us. Yes.
Yes, I'm
Perfect.
here.
Thank you so much for switching on your camera, and welcome, and thank you so much for joining us. So after listening to what Leah shared and about this decision-making capacity and how much does a young patient have a say in their treatment, I would like to hear from you, from a clinician's perspective, from your practice. What do you think about this decision-making capacity? Does a young patient
Yeah. So,
get to have a say in an Indian context?
no, so it is very important because in elderly population, decision is generally made by someone uh, who is either a caregiver or someone like that. But the younger population, less than 40, they would generally ask for all the details. They would have a lot of questions. They would have a lot of apprehension because a lot of things is dependent on them. So it is very important to counsel them all the options also and to discuss their apprehensions. So if we do that well in first month, most of the things are sorted for them for next 6 to 8 or 12 months. So it is very important to keep them at center while you decide whether it is treatment or the diagnostic part or anything. I've seen a lot of patients now having access to AI models, and uh, they may do it live while they are in OPD, or they would go back, do the questions, and come back with the questions to ask. Uh, if we don't include them in discussion, sometimes they would give wrong uh, feeders or wrong input to AI model, and they will have wrong answers to it, and they would believe that that is more correct than what doctor has told to them. So it is very important to discuss most of the things with these patients. They are not like if you are treating someone in 60s or 70s, where you have suggested that this is the best option for you, and they would accept and start treatment. We need to discuss all the options, why we as a doctor have selected ABC option for you, and these are XYZ options, pros and cons of all the options. And then probably if you have discussed them, give them time, maybe a day or couple of hours, they will come back with a better answer, and they will be more confident in the treatment while you are treating them. So I personally believe that this is an important thing to be done for the patient. Second point I would tell is, again, it is different for a patient who is from tier 1 city or tier 2 city or tier 3 city. The counseling part or the expectation part also differs. So as a clinician, you need to adapt to it also.
Absolutely, absolutely, Dr. Rishabh, and thank you so much for sharing that. We have Rishikesh with us, who is also a young patient advocate who was diagnosed at 24 years of age. And he would like to share with us his experience of diagnosis and also how his career and his finances were impacted because of the diagnosis. So, Rishikesh, जर तू शेअर करू शकतो की लंग कॅन्सर डायग्नोसिसमुळे तुझ्या करिअरमध्ये आणि फायनान्शियल लाईफमध्ये कसे चेंजेस आले आणि तू ते चॅलेंजेस कसे मॅनेज केले?
येस मॅम. माझा आवाज येतोय ना?
हो हो, परफेक्ट येतोय.
बिफोर डायग्नोसिस मी पुण्याला ॲज अ मेकॅनिकल इंजिनियर जॉब करायचो. पण ज्यावेळेस डायग्नोसिस म्हणजे ज्यावेळेस मला त्रास चालू झाला, त्यानंतर जेव्हा डायग्नोज झालं की लंग कॅन्सर आहे, तेव्हा मला तो जॉब सोडून माझ्या होमटाऊनला शिफ्ट व्हावं लागलं. त्यामुळे जे काही एज्युकेशनल बॅकग्राऊंड होतं मेकॅनिकल इंजिनिअरिंग आणि जी आवडीची फील्ड होती, ती सोडून कम्प्लिटली मला होमटाऊनला शिफ्ट व्हावं लागलं फॉर फर्दर ट्रीटमेंट. आणि त्यानंतर जेव्हा पूर्ण ट्रीटमेंट कम्प्लीट झाली, जेव्हा मी रिकवर झालो, त्यानंतर आता काय करायचं, या करिअरमध्ये तर काहीतरी करावंच लागेल असा विचार केला. त्यामुळे मग मी माझं स्वतःचं रेस्टॉरंट चालू केलं, कारण त्या फील्डमध्ये थोडा बहुत इंटरेस्ट आहेच. पण ते चालू असताना सुद्धा असे चॅलेंजेस आहेत माझ्यासमोर की त्या किचन मधून येणाऱ्या फ्युम्समुळे मी किचन मध्ये जाऊ शकत नाही. आणि रेस्टॉरंटमध्ये इट इज इम्पॉर्टंट की ओनरला किचन मध्ये लक्ष द्यावंच लागतं. त्यानंतर मी जसं पहिले 12 ते 13 तास कंटिन्यू काम करू शकत होतो, तेवढी धावपळ मी आता करू शकत नाही. कुठेतरी त्या गोष्टीत लिमिटेशन्स आलेले आहेत. त्यामुळे मला असं वाटतं की माझे जे फायनान्शियल, त्यानंतर करिअर गोल्स जे होते, ते कुठेतरी खूप कॉम्प्रोमाइज झालेले आहे आणि डिलेही होतीलच ऑब्व्हियसली. तसंच या डायग्नोसिसमुळे करिअरमध्ये नाही म्हटलं तरी 4 ते 5 वर्षाचा सहज सेटबॅक आलेला आहे. आणि एकदा डायग्नोज झाला, ट्रीटमेंट केली, पण त्यानंतर परत 1-1.5 वर्षांनी रिकरन्स झाला. त्यामुळे मी जो रिकव्हरी केल्यावर कामाला लागलो होतो, त्यानंतर परत रिकरन्स झाल्यामुळे कुठेतरी ती ट्रीटमेंट, मग त्या ट्रीटमेंटचा होणारा साईड इफेक्ट, यामध्ये माझं जवळजवळ आता 1.5 वर्ष गेलाय. आणि त्यामुळे जो परत करिअरवर फरक पडला की इनकन्सिस्टन्सी आली आहे त्यामध्ये. त्यामुळे असं मला असं वाटतं की आता ज्या मी एज मध्ये आहे, जिथे मला असं बरेच वाटते की मी माझ्या घरच्यांना हेल्प केली पाहिजे त्यांच्या फ्युचरसाठी. त्यानंतर माझे काही फ्युचर गोल्स आहेत, त्यासाठी मी काम केलं पाहिजे. या गोष्टी मी करू शकत नाही आणि त्यामुळे मेंटली कधी कधी खूप डिस्टर्ब होऊन जातो. आणि फायनान्शियली बोलायचं झालं तर फॉर्च्युनेटली मला तेवढा त्रास गेला नाही पूर्ण ट्रीटमेंटमध्ये आतापर्यंत पैशाच्या बाबतीत. पण मी बरेचदा मी ज्या हॉस्पिटलमध्ये जातो तिथे ऑब्झर्व करतो की भलेही गव्हर्नमेंटच्या स्कीम आहेत ज्या आपल्याला हेल्प करतात ट्रीटमेंट घेण्यासाठी मेडिसिनच्या कॉस्टसाठी, पण त्या करता करता असे चॅलेंजेस येतात पेशंट समोर की समजा त्या स्कीम मध्ये अप्लाय केलेला आहे, त्यामुळे किमोची जी काही शेड्यूल दिलेला असतो तो 4 ते 5 दिवस डिले होतो. त्यामुळे ट्रीटमेंटमध्ये तेवढा डिले झाला तर मग पेशंटच्या हेल्थवर तेवढाच फरक पडतो. आणि त्यामुळे त्या स्कीमला पहिले अप्रुव्हल घेणे, मग ते अप्रुव्हल 4-5 दिवसांनी येईल, त्यानंतर मग ट्रीटमेंट चालू होईल. या गोष्टीमुळे पेशंटचे जे काही चक्र आहेत हॉस्पिटलमध्ये त्यामुळे त्याही वाढून जातात आणि तो त्रास होतो. हा सगळा माझा एक्सपिरियन्स आहे आतापर्यंत.
Thank you, Rishikesh. Thank you so much for sharing. What we're hearing from Rishikesh's story is because being diagnosed at such a young age, he had to leave something that he really loved and enjoyed doing, mechanical engineering, and then had to take a break for the treatment and everything. And then now he managed to open a restaurant with the help of his father, but yet is struggling to take care of his responsibilities fully by himself because of the physical restrictions of his body and his treatment effects and everything. And so I also want to highlight this, that young patients who get diagnosed at a very young age mentally are in this stage where they want to be the caregivers to their parents, but then suddenly have to suffer this blow that now they no longer can do that, but they need to ask for help and someone is going to help them, which is really emotionally disturbing. I have been through that exact same situation, and uh, I can understand what Rishikesh must have felt, and all of the patient advocates from whom we heard about their stories. So that was all for our webinar. These were the questions that I wanted to bring forward and have discussions on. We now will have open discussion where we all can interact and talk about the research ideas that we were just talking and how to make them practical. But before we get on that, can I please request everyone to switch on their cameras? We'll just take a quick screenshot so that we can have a nice post of this webinar, and then we can go ahead with the open discussion. Yeah, if I may ask Sanjeev ji, Rizwan ji, Suchismita, Amber ji to also switch on their cameras. Just a quick screenshot. And yes, everyone smile. Thank you so much. I've got the screenshot. Thank you so much. And this was really wonderful. So now, as part of the discussion that we were having, we've shared a lot of thoughts, a lot of ideas, a lot of concerns here. I think the key points that I want to again bring forward is one, the delay in diagnosis that has been repeatedly brought forward internationally and in India. Second, of course, the financial burden, especially being a young patient who doesn't have much of savings and has to take support from their family. Third, this emotional burden that a young person who now has to change his whole idea and whole plans of life and suddenly has to become someone who needs care. So that emotional burden. And then, of course, we all discussed about doing some research and what is the best way forward to it. And I would really like to probe this discussion in the direction which Dr. Ullas very nicely put, that what is the practical outcome out of this? So I know a lot of times research does turn to just end up being a publication or a paper, but I really want to hear your thoughts on how we can then use that research into actually practical solutions which would help to ensure that these problems that have been discussed are dealt with. So yes, I'm opening it to all of you, whatever thoughts you have to share. I know Dr. Ulhas is eager to talk, but he's waiting for someone else to unmute.
Let me ask Upal.
I think my big thing here is once we've done the research, we need to use that information to actually drive some kind of change for our patient and caregiver community. And in my mind, change is going to happen at the clinic level. So we have where clinicians have a better understanding of first the presentation of people with lung cancer and doing more sequencing, making sure that they get matched to the right targeted treatment. Then the other piece is the sort of the psychosocial aspect of this. I think Leah pointed out, right? And I think we heard this from several people that it is a big loss of identity when you are being diagnosed with lung cancer. And I think making sure that young people diagnosed with lung cancer have that support system, and that should be a part of that clinical discussion as well, making sure that the mental health needs of patients and their families are addressed. And last but not least, and I think this has to be really a bigger policy level kind of discussion, and Leah, again, you alluded to it, sort of that financial aspect of a diagnosis, which I think is very, very critical, because not only are you losing income because of cancer diagnosis, but very often young people are really in that sandwich generation, right? They're taking care of their children and they're taking care of their parents at the same time. So that loss of income can have very devastating consequences. So I think, again, Dr. Batra, to your point, I think the first step is, of course, doing this assessment of needs. But I think the more critical piece is taking this information and creating sort of better support systems and fertility preservation layer. Again, that's a very important point, because again, younger people in the lung space, at least, we don't talk about fertility preservation. I think in the breast cancer space, when younger women are diagnosed with breast cancer, very often the oncologists will have that fertility preservation discussion, but we know that that's not happening in the lung space. So again, to summarize it, I think getting the information, but I think most importantly, creating programs in collaboration with oncologists, with treating physicians, with the health systems, and I think with even governments as well, because some of these solutions have to be policy level solutions, making sure that our patients feel supported. And this is not a 1 year goal. This has to be a couple of years, but I think we need to make this investment.
So my 2 cents on this, Rasika, would be needs of patients are different. Like somebody who comes to Muzaffarpur is totally different from somebody who comes to Mumbai, is very different from somebody who comes to a quasi-private or a trust hospital like Rajiv Gandhi. So I think first of all, any assessment that we do would be a hypothesis generating, and probably asking a further research question about how can I better serve my patient. So probably in my setting, finding a room may not be that difficult. Kumar lives in a palace. We live in a single room, this thing. So anybody who walks in the Rajiv Gandhi will know where we sit, and not like a palace that they have. Anyway, so that is one. So for me, probably somebody we get a lot of patients from Nepal to do a second consultation, to do some testings, do a PET CT scans or something. And as Upal was just talking, I was thinking, one part is the diagnosis and everything. But overall, we say two things. One, participation in clinical trials is very low, because less than 1% of our people actually get involved in a clinical trial. So if you really want to, ask that question, ask, what do you think about clinical trials? If we can get 3% or 5% of more people to enroll into clinical trials, things will become hugely different for them, and for the entire infrastructure of India. One. The second thing which actually came to my mind that when Dr. Kumar was speaking about was less than 50% of people, or only 50% of people, will take second line treatment. If we can involve a counselor or a psychologist to understand, somebody who is going to be there with them in their journey, telling them, okay, hey, it's okay, first line treatment has not, we have some second line. A lot of time we see people just drop off the treatment. if I can increase that second line of treatment. So for me, as he rightly said, maybe so the practical aspect of this questionnaire would be, just on the top of my head, would be clinical trials enrollment and continuum of treatment. Don't drop off. People do go off to the other lines of treatment, Ayurvedic, homeopathy, this, that. Absolutely okay, but continue the treatment. And the third one probably would actually be, maybe as Lung Connect, we can have a system of second opinions. If I want to send somebody for a second opinion somewhere, if we can facilitate them seeing the God himself in Muzaffarpur or in Mumbai, I mean, that also might just be a good way to help people so that they stay on the treatment. Maybe a teleconsult, video consult, something of that. So this is something which came from how happy are you with teleconsultations? Uh, that's a very, I mean, people, if they can do a teleconsults at that time, does it work? So something of that sort should really come into the ones which allows people to take more people to take the treatment, expand the kitty. More people should take treatment. That's it.
Thank you so much, Dr. Ullas. Dr. Kumar, any final thoughts, key points that you would
Mar's thoughts
want
are
to
always final only. He's a final word.
Ullas is a dear friend, and so I think so. What has been discussed is important, that we find something and we work on it. That is very important. And part of it also, we work on it. It will be very useful. So if we find 10 things, if we are able to provide solution to 3, 4, that will be an excellent thing to happen. So let us take the first step. I'll be happy to work. Ullas has also agreed, so we know that we have two people from two different parts of the country where we can have some valuable information from.
Thank you so much, Dr. Kumar. Leah, any final comments, thoughts you would like to share?
I think that this is a great conversation. I love the idea of incorporating patients and their different needs, because as you all are saying, depending on the hospital they're at, we have the same thing going on here. I'm in a very rural area, and I do travel to Houston, Texas from Kentucky for my care, which is a plane trip. So I understand what it's like to have different needs for different groups. And I think another critical question here is, when you're meeting with these people, because at least in the United States, the varying degrees that people can read and understand, like take in the information. A critical question is, how do you like, or what is the best way for us to relay information to you? Would you like it written? Do you want someone to talk you through it? Do you want a pamphlet to look at? Do you want a website? Because everybody learns differently, whether it be visually, auditorily, whatnot. And also, as somebody in the sandwich generation, we're going home to explain this to our children that are younger than us, that are asking questions, but we're also going to try to explain it to our parents who are older than us. And the way all three generations learn is very different. And the ones of us in the middle are kind of the one that bridge those two places. So just having different, ways to present the information, I think, is very important as well.
Yeah, I totally agree, Leah. And thank you so much for sharing that. Dr. Rishabh, do you want to share any final comments, thoughts? If you're still.
Yeah, so I would agree that finding problems and identifying them and trying to solve whatever is possible from whatever resources are available. Resources available for every clinician, every hospital are very different. So we should try to identify our problems and try to solve whatever we can do from available resources, and at least intent to find the problem and solving them would be a great initiator.
Yes, absolutely. And I'm sure all the patient advocates and all of us agree with this thought that that is what we all are here to work for, that the intentions is to get things rolling and make the situation better. A huge thank you to all of you for joining us today. This was really rich conversation, and a lot of ideas have emerged, and I hope that we will start working on them as soon as possible. But a special thanks to Rishikesh, Raviji, and Rishu, who very kindly agreed to join us I'm really sorry if this conversation was not in your local language because we had to accommodate the international participation. But I'm so happy that you all continue to stay till the end of the webinar and shared your stories with us. Being a patient myself, I know how difficult and how heavy it is to just share your story again and again because it is really a very emotional aspect. So yes, a huge thank you to Raviji, Rushikesh, and Rishu. And again, thank you so much, all of you who joined and made this webinar such a huge success. This is going to go live and on our YouTube for everyone to watch. So if you uh, if you want, you can share the link with people in your organizations or to the patients. And we will definitely work on the collaborative ideas that we discussed and send a few emails or WhatsApp texts so that we really get the ball rolling on the things that we discussed. Once again, thank you so much.